Today I am going to talk on the topic of hypophysitis, nonsense in diagnosis and management. This will be a case-based presentation where we'll be sharing the rich experience which have been gained at the Department of Endocrinology, KM Hospital, Mumbai. We all know hypophysitis is etiologically divided into primary and secondary form. The primary form is idiopathy, which is diagnosed when rule out the secondary form, which to rule out underlying systemic autoimmune or granulomatous and infectious or infiltrative disorders. The pathologically, hypophysitis has been subdivided into lymphocytic granulomatous, xanthomatous, or necrotizing subform. Radiological classification is also there, which is based on the affection of the anterior pituitary, that is termed as adenohypophysitis, where the hormonal involvement is preferential ACTH involvement, followed by thyroid and gonadotropes, and followed by growth hormone axis. The second one is the predominance of stalk and posterior pituitary involvement, that is known as infundibulous neurohypophysitis, where we can see a central diabetes insipidus. And in very rare cases, there can be affection of growth and gonadotropin axis. The third one is the affection of both anterior as well as posterior pituitary function, that is termed as panhypophysitis, where the clinically the presentation will be similar to adenohypophysitis, as well as there can be a presence of DI. So the diagnostic clues are from the history point of view. For the lymphocytic hypophysitis, it is a peri or postpartum onset of symptoms. In the case of secondary hypophysitis, there may be associated symptoms of underlying autoimmune, inflammatory, and infectious disorders. In case of newly described the drug-induced hypophysitis cases, there may be a pertaining history of exposure to immune checkpoint inhibitors or interferon alpha. Uh, for us, the endocrinologist, the main thing is the biochemical clue that we should not forget. That's the form of, if we see hormonal deficits which are out of proportion to the size of cellular lesion, then we should suspect hypophysitis. And in these cases where there is adenohypophysitis, there will be predominant involvement of HPA axis, which is followed by gonadotropin and thyrotrope axis, and the least affection will be in the growth axis. But in the most cases, the diagnosis is based on the characteristic MRI findings with a Gutenberg score of 0 or less. So these are the typical imaging features in a case of hypophysitis, where most of the cases with adenohypophysitis will present with a definite cellular mass, which has a homogeneous contrast enhancement. In a case of infundibulous neurohypophysitis, there will be a predominant involvement of stalk thickening as well as loss of posterior pituitary hyperintensity. Uh, Supracellular extension is also seen in majority of cases, and in half of the cases there can be a characteristic T2 dark sign, that is a T2 hypointensity on the MRI, which suggests chronicity of the inflammation. In some cases, there may be extension in terms of figure of eight appearance, uh, and uh, and some cases it can be a paracellular extension. Cystic changes are also seen in some cases, like drug-induced hypophysitis and granulomatous hypophysitis cases. In some cases, the inflammation leads to hypervascularity of the surrounding dura, that leads to a dural tail sign, dural hyperintensity. The Gutenberg score is a clinico-radiological score that leads to a non-invasive diagnosis of hypophysitis. That is, the parameters are based on the clinical history as well as the MRI features, and a score of 0 or less will lead us to diagnosis of hypophysitis. A score in 1 or more will lead to diagnosis of adenoma, and in a smaller series, the sensitivity and specificity of 97 and 99% was described by Gutenberg et al. Coming to the natural history of hypophysitis, most of the patient will present with a cellular mass in the stage of acute inflammation. and which will over the months time with or without any treatment will regress with a corresponding regress in the clinical mass effects. Some cases there can be a clinical evident relapse with cellular inflammation going on again, and most of the cases, if we don't intervene, will turn out to be a partial or complete empty cell on the follow-up of years. So the coming to the management options, the goals of treatments are threefold. First is the resolution of acute mass effects. The second important thing is the replacement of deficient hormones. And on the long run, the most important goal is the recovery of lost pituitary function. So the conventional management options that are transpenoidal surgery and observation that leads to poor recovery of anterior pituitary functions. And in the case of TSS, there can be a new onset of pituitary deficit in about 45% of cases. So in a retrospective study in 2014, we have published our own experience in pituitary, where we have shown that 33% cases there can be complete or partial recovery of anterior pituitary function with watchful observation alone. But this, as we know, it's a suboptimal recovery. So then after we switch over to third mode of treatment that we have exemplified in these following two cases. A young female presented with acute onset history of headache and vomiting, and there was diplopia and evident right six nerve palsy. The MRI was done that identified characteristic features of adenohypophysitis, and biochemically there was affection of HP axis with hyperprolactinemia. So, after ruling out secondary causes, the patient was treated as for the other neuroimmune conditions, that is IV MPS pulse therapy, 1 gram for 3 days, followed by oral steroid. And over 1 week, there was resolution of clinical mass effects, and over the months, there was resolution of the radiological features of hypophysitis. And the most important thing, there was recovery of HPA axis on the follow. Similarly, in the second case, a 39-year-old female presents with amenorrhea and headache, and there was acute onset right third no palsy. Again, the imaging features suggested evidence of adenohypophysitis with the affection of cortisol as well as the gonadotropin axis with hyperprolactinemia. So, similarly, after ruling out the secondary causes, the patient was treated with pulse steroid therapy, and in 1 week there was partial resolution of third no palsy, which resolved completely over the follow-up after the oral steroids, and also there was resolution of the pituitary mass with recovery of cortisol axis, but the gonadotropin axis did not recover. So this also in a smaller series we have published in the same article that in out of the four cases, three cases had a complete and one case had a partial recovery of anterior pituitary function with a steroid pulse therapy. So this became a standard of care in our department after that these patients with primary hypophysitis are being treated with a standardized 3 days per 1 gram methyl prednisolone pulse therapy that is followed by 1 milligram per kg oral prednisolone dose for 4 weeks and followed by a 5 to 6 weeks oral steroid taper. So this experience has extended now to 18 patients, and fortunately we have a control arm in the form of observation for the previous patient. And fortunately, this baseline parameters of these both groups matched. So the comparative arm was there for the steroid group, and radiologically also this both group matched except for the higher pituitary height in the glucocorticoid arm that suggests that over the years we have graduated to earlier suspicion and diagnosis of these cases in the phase of acute inflammation. So when we compared the outcome data of this two groups, we could see that there was a double, when we compared the overall recovery of anterior pituitary function, it was almost double than the observation group. And when we compared the complete recovery arm, it was almost tenfold. So there was tenfold higher recovery, higher complete recovery chances in the case of patients who are treated with glucocorticoid pulse therapy with primary hypophysitis. And this trend persisted for the individual hypothalamo-pituitary axis, but we could not see a recovery of DI in any of the involved patients. Again, the radiological progression to anti-SELA was also halted with this pulse glucocorticoid therapy. And the most important thing, there were fewer recurrences than the other published literature, and there was no major glucocorticoid related adverse effect because the overall duration of the glucocorticoid therapy was smaller. That's the 10 weeks. So these are the published literature where the majority of the studies where the steroid was used in the management of primary hypophysitis have been dedicated. And first one is that by Christoph in 1999. It was a prospective study, used the pulse steroid therapy, but the dose was 120 milligram. It was a non-randomized study. There was no control group, and they showed a 50% partial recovery rate without any recurrence with steroid therapy. Again, there were two studies in 2017. Both were retrospective and treated. The patients were treated with oral steroids for a longer duration of time, but showing a suboptimal recovery and a higher recurrence rate. Only one prospective study afterwards was published that was with oral steroids. Again, there was no match control group, and the duration of treatment was higher. It was almost 13 months. And so there was no recurrence, but the recovery was seen in 70% cases only. So this is our present study data, which is again a retrospective study. The patients have been picked up earlier, treated with a homogeneous steroid regimen. The overall treatment duration is shorter, resulting in a fewer adverse effects. We have a match control group that can show us the natural history of disease if left untreated, and the treatment efficacy is highest with an acceptable recurrence rate. We also try to identify the predictive factors for complete recovery of anterior pituitary axis. And when we compared the data, we identified that those patients who were diagnosed earlier in the phase of acute inflammation and treated with pulse steroid, they had complete recovery of anterior pituitary function as compared to those who presented or diagnosed late and treated late with just pulse therapy. So the strengths of our data, it's based on standardized protocol of treatment using a pulse glucocorticoid therapy, and early non-invasive diagnosis and treatment can lead to a complete recovery of anterior pituitary axis. This was consistent with earlier observation by Christoph et al. In 1999. A role of DI in anterior pituitary axis recovery remains debated, with one study saying it's an adverse prognostic factor, a second study saying it's a good prognostic factor. But in our study, we could not identify any predictive role of DI, but actually in our study, the number of patients having DI were quite few. So, this up to this data, we say that primary hypophysitis patients should be treated with a pulse glucocorticoid therapy to improve the clinical, hormonal, as well as radiological outcome. Now, does this benefits extend to other cases also? So this is exemplified in the next case, where a 22-year-old female presented with a history of 2 weeks history of polyuria polydipsia and a polychronial headache. The hormonal parameters showing hyperprolactinemia as well as central diabetes insipidus, and MRI findings suggest of panhypophysitis. Looking for secondary causes of hypophysitis, we found raised IgG4 level, and to rule out any underlying systemic IgG4 disorder, FDG PET was done that showed no systemic uptake. So the patient was treated with a similar pulse steroid therapy, and there was clinical, biochemical, as well as radiological recovery. And now the patient is put on surveillance for possible recurrence. So this is a case of primary IgG4 hypophysitis. These patients also, as the pathophysiology is similar to lymphocytic hypophysitis with plasmoid cell infiltration into the cell, they respond well to the pulse steroid therapy. Now, we know all the cases are not so fortunate. A similar case, a 47-year-old female with episodes of headache, cranial nerve palsy, and progressive diminution of vision presented to us and had a temporary response to glucocorticoid and had three clinically evident relapses with glucocorticoids. And on follow-up, she became pan-hypopituitary. She developed pan-hypopituitarism. So the MRI was done that showed the inflammation of sella to the surrounding region of hypothalamus, And this patient was worked up for the underlying causes of secondary hypophysitis that turned out to be negative. So the diagnosis of autoimmune hypophysitis with hypothalamitis was made. As the patient was refractory to steroid therapy, she was started on other therapy. So in such recurrent and refractory cases, the most obvious treatment will again remain the repeat course of pulse glucocorticoid therapy, and we have seen in two cases that it is effective and well tolerated. But in such a case where it is persistent or refractory to treatment, then we should try surgery or other immunosuppressants like azathioprine, rituximab, mycophenolate mofetil, methotrexate, and cyclosporine. They all have been described with one or two case reports in the literature and having good response to therapy. And now, again, coming to a newer etiology of hypophysitis, there's a 56-year-old female with adenocarcinoma of lung receiving chemo and radiotherapy, but still having persistent disease. So, started on a newer therapy, that's immunotherapy, durvalumab. So, that's the immune checkpoint inhibitor, PD-L1 inhibitor. The patient had received three cycles of immunotherapy and then developed fatigue and weakness. So the treating oncologist advised for the pituitary function profile and that identified primary hypothyroidism with hyperprolactinemia with central hypocortisolism. So an MRI was done that turned out to be normal, and this patient was diagnosed to have immune checkpoint inhibitor induced hypophysitis with primary hypothyroidism. So there are two groups of immune checkpoint inhibitors commonly used that are CTL4 inhibitors and PD1 and PDL1 inhibitors. The incidence of hypophysitis is higher and earlier with CTL4 inhibitor as compared to the PD1, PDL1 inhibitors where it is lower and later. Because the CTL4 is expressed on the anterior pituitary cells, the incidence of hypophysitis is more. And similarly, the affection of anterior pituitary axis as well as the MRI characteristics are more like a primary hypophysitis in CTL4 inhibitors, whereas in PD1 or PDL1 inhibitors, it is predominantly isolated ACTH deficiency with normal MRI and a permanent ACTH HP axis damage. Other endocrinopathies like thyroid disorders are seen in higher numbers with PD1, PDL1 inhibitors, and there can be some cases of type 1 diabetes mellitus. So, as these cases they have underlying malignancy, ruling out a pituitary metastasis is essential before we go for a diagnosis of hypophysitis. So, a size of more than 2 centimeter or a mass with heterogeneous enhancement with cavernous extension suggests a diagnosis of metastasis as opposed to hypophysitis in this group of patients. Clinically, those patients who are started on immune checkpoint inhibitors, they should have a baseline as well as 8 and 16 weeks follow-up of anterior pituitary axis. And if any of the axis is found abnormal, there should be an imaging confirmation. As the underlying pathophysiology is different from the primary hypophysitis, here it is antibody and complement mediated direct anterior pituitary cell lysis rather than any lymphocyte infiltration. The treatment is different. So here this on routine cases should be managed with a replacement dose of steroid, and pulse steroid is only indicated where there is evident mass effect on MRI or clinic. Now, the ruling out the secondary causes of hypophysitis is very important before we begin this pulse steroid therapy. This is exemplified in the next case where a 27-year-old female presents with amenorrhea and a goiter. And when she was referred to us, we identified she had a history suggestive of diabetes insipidus and a cranial headache. So the anterior pituitary hormone function was done that identified affection of growth, gonadotropin as well as HPA axis with hyperprolactinemia, and the central DI was confirmed with water deprivation test. So this patient was basically a case of panhypopituitarism and goiter. And looking at our rich experience in diagnosing hypophysitis cases, we thought that it will be a case of lymphocytic hypophysitis with associated Hashimoto's thyroiditis. But the MRI was done that showed us hypophysitis with the extension of inflammation to the hypothalamus. And we had done the biochemical evaluation for ruling out underlying causes of systemic disease that turned out to be negative. But as we stick to our protocol, HRCT was done and that identified multiple cystic as well as a nodular lesion in bilateral mid and upper zones of lungs, and FDG PET CT showed uptake in the thyroid as well as surrounding some lymph nodes. So FNA from thyroid was advised, and that turned out to be Langerhans cell histiocytosis. So this patient was treated with chemotherapy and not pulse corticosteroid. So to conclude, hypophysitis is a rare diagnosis that requires high index of clinical and radiological suspicion. Lymphocytic hypophysitis is the most common subtype that is characterized by classical radiological features. In most cases, it will be homogeneous contrast enhancement in an enlarged pituitary. And in cases of INH or pan hypophysitis, there will be thickened stalk as well as loss of posterior pituitary bright spot. Early recognition and treatment of these cases with high dose pulse glucocorticoids can lead to better clinical, hormonal, as well as imaging recovery with fewer recurrences and adverse drug effects. Ruling out secondary causes of hypophysitis is of utmost importance before we give pulse steroid therapy. And refractory cases can be treated with other immunosuppression or surgery. Hypothalamitis can be seen as an upward extension of this pituitary inflammation, and it requires evaluation and treatment as for hypophysitis cases. IgG4 hypophysitis is a new entity that requires evaluation for underlying systemic disease, and a prompt treatment with glucocorticoid will result in a good outcome. Whereas ICI-induced hypophysitis should be recognized and treated with replacement dose of steroids in cancer patients who are treated with this immune checkpointing inhibitors. So with this, I end my talk and will invite any questions regarding hypophysitis.